So after all the foreshadowing from Arlene and Julio, I'm not sure that I really need to introduce Julio. I'm sure most people here have crossed paths with him before, but the formalities, kind of off the top of my head, are Julio has been director at the BC Centre for Excellence for what seems like forever. It's not actually that long, 7, 8 years maybe. Is a professor in the Faculty of Medicine at UBC. Is the past president of the International AIDS Society, which is an easy thing to trip off your tongue, but has a phenomenal amount of global impact behind it, frankly. The AIDS conference held here in Vancouver back in 1996 was at the time, I think, the very largest conference that had ever happened in this city. And it's only got bigger since then. It's the largest global gathering on a health issue that I'm aware of, and so a lot behind that. And quite recently, Julio was awarded the Order of British Columbia in recognition of not just what he's done here in BC, but what he's done on the global stage. So there's the formal bit. The informal bit is I've had the privilege of what Arlene referred to as a private tutorial, of watching and listening and being with Julio as he has used data and an ever-growing amount of it to brief all sorts of folks, minister after minister, deputy after deputy, folks all over the place. And for me, he's taught me just how important it is to use data to tell a compelling story. He's a real master at it. And if any of you have a pillar between you and these screens, I'd suggest you shift your seats so you can have a good look. So please welcome Julio Montaner.
Thank you, Warren, and thank you, Arlene and Chiro. Arlene, you were more than kind. I have two big drawbacks. My children say that I'm an ESL, and so, and I'm not. Well, I am. I don't know. And they say that I have a speech impediment. And I don't know which one of the two is responsible for it anyways. But so bear with me. The other one is that I speak very fast. And it doesn't matter what I do, I can't fix either one. So you know what, I'm sure many of you have heard these talks before, at least in bits and parts. And so by hearing many times, then I adjust for the deficit. The other one, sort of a spin-off of this, is that I need things to be very, very clear. I don't know if because I need them for me to understand them, or because that's the way I sort of grew up. I liked things to be black and white. And so my drive to go after the data is because that's my guiding principle in terms of where I'm going to go and what we're going to do. And so what Warren was describing is really the principle that I embrace all my professional life and has served so well to the work that we've done for HIV and AIDS, as I will show you. I do. The reason why we're here really is because over the last many years, since 1996, when we first discovered here in BC in part, and brought to the world triple therapy, highly active antiretroviral therapy, we recognized very quickly that this had a tremendous impact in the morbidity and mortality of people with HIV, but unexpectedly at the time, we saw also that there were two phenomena taking place. One, that the number of HIV new diagnoses that we were identifying in the province were going down, and that could not be explained by changes in sexual behavior, as demonstrated by the fact that syphilis rates were going up at the same time. And the other one is that the epidemic of HIV among children, neonates, basically faded away. And of course, it's not because we were not working at it and doing a good work about it, but the real fact is that triple therapy really addressed that issue very, very effectively, to the point that, as Chiro said, the first objective of our program, if you want, has already been accomplished to a great extent. The problem is we had to make that sustainable. In other words, we had to continue to prevent children from being born with HIV, which is totally doable, and in fact, we're doing it. Inspired by those data and a variety of other issues that I'm not going to get into details today, we were invited really by Penny Ballum, at the time, the deputy minister, to put this evidence together to support our contention that treating people with HIV was associated with, no, doesn't matter, with a decrease in HIV transmission. So we argue, as you see in this slide, that highly active antiretroviral therapy stops HIV replication. When that happens, the viral load becomes undetectable. From the perspective of the infected individual, this means that the immunity recovers, the CD4 counts get better, the disease gets into a remission state, and basically we are looking today, based on our own data, for a 20-year-old infected individual, recently infected, recently diagnosed, approximately 63 years of preserved quality of life ahead of them. So we're looking at a guy or a person in front of us that you can reasonably say, you better pay your taxes because otherwise they're going to come after you. When I started practicing in this field, people say, so now I can stop paying taxes because I've been diagnosed. Well, that doesn't work anymore. This has been a very, very dramatic change. So I made that point because we're here talking about prevention, and many people feel that we are doing this because we want to prevent an epidemic. Really, the reason why this program came about is because we wanted to optimize the management of people infected with HIV, and by recognizing that treatment plays a critical role on the overall strategy, that allow us to release the resources that were needed in a very difficult economic times to support people who needed access to treatment, and actually to continue to go after them more aggressively at times in which the healthcare system was operating in a fairly constrained fiscal environment. In any case, as the viral load falls to undetectable levels in the plasma, which is the driver of the recovery for the infected individual, it also falls to undetectable levels in all biological fluids, including semen, vaginal secretions, rectal mucosa, and in fact, other tissues, wherever you look for it. And this correlation is very tight, and as a result of that, we concluded that if we always knew that more virus was associated with more effective transmission for every single encounter, less virus should be associated with less likely transmission. And so with this data in hand, we asked Bob Hogg, a demographer and epidemiologist working with us back in the day and still today, to put some of these estimates together and look at hypothetically what would be the theoretical impact that universal treatment could have in a given community. And we picked up South Africa to make this more interesting and relevant. And what you see here on the orange line on your left-hand side, the upper quadrant, is that if we continue to treat, as it was the recommendation in 2006, conservatively, people, before they get sick, what you see is an epidemic that continues to grow and stabilizes at a higher rate, at a higher level. On the other hand, if you use a hypothetical, only a computer can do this, but if you use the hypothetical approach of identifying everybody all together and treating them all at once, what you see is that the epidemic basically extinguishes itself. And why is that? Because the effectiveness of antiretroviral therapy to prevent infections, as showed in the panel below, is huge. And so you're saving both morbidity, mortality, and also new infections. And so because you're saving new infections, on your right-hand side, now you see that the cost of treatment of what is called a conservative approach actually is not sustainable. The cost goes up and up and up and up because the epidemic continues to grow and you're accumulating more and more people in need of treatment. So the smart approach is to have a more aggressive approach at front, which at the end of the day, very shortly thereafter, within a decade, as has been now confirmed by WHO, and I'll show you those data shortly, will lead to a dramatic decrease in the expenditure to the point that over a decade or two, you're really laughing all the way to the bank. So this is actually a cost-averting strategy that, as Premier Campbell, who I owe a great debt of gratitude for the support that he gave us at a time which most people thought that we were out to lunch back in 2006 and thereafter. As he used to say, this is good for the patient, this is good for the public health effort, and this is good for the public purse. He used to call it the 3 Ps, and I fully agree. If appropriately used, this is also good for politicians as well. Didn't work for him very much, but anyways, we came out with this proposal in 2006, and that at the time was regarded as highly controversial. But as Warren told you, that was the same year that I had the opportunity, the privilege to be nominated and eventually given the access to the presidency of the International AIDS Society. I did not even anticipate the impact that that could have on this effort. I really never planned it this way. But as a result of that role, I had an opportunity to discuss this kind of thinking with a lot of very influential people. And this guy here actually was very, very instrumental on changing attitudes around the world for us regarding this issue. And in 2008, when he saw that things were not moving fast enough in the right direction, he started to talk publicly about it, in this case to the Wall Street Journal, saying basically that in the absence of a cure, we should be just doing this. And fortunately, BC has been doing this, and I'll show you what the impact has been as a result of it. In all honesty, at the time that we started this work, and this is something that I was not particularly happy with, I had one lingering concern, and that related to what extent treatment as prevention would be as highly effective in injection drug users as it would be in other groups. The epidemiological cohort data suggested that mother-to-child transmission, that's a go. Sexual transmission is a go. But injection drug users, the level of needle sharing can be highly problematic in these groups. The dead space of the needle can be very large, and so the inoculum can be huge. And so even if there is very little virus per milliliter of blood, if you have a very large inoculum, that was very worrisome. And we struggled with this. And I want to give the credit to Evan Wood because he actually came up with an idea that was unique, and he basically argued that the way to look at this was no longer looking at the individual level, but looking at the community level. And that's the way the notion of community viral load was born. It led us to look at this issue in the downtown east side. And for the first time, without going into the methodological issues, we were able to show on the blue that in the downtown east side, among HIV-infected individuals, when we brought treatment to the people, we saw a decrease in the community viral load. That's the average viral load, or the amount of virus circulating in the community. And what you see is that that precedes the HIV incidence. This is true HIV incidence measured prospectively in the downtown east side community among IDUs who were, of course, previously HIV negative. The level of this association was so strong that, in fact, it was 10-fold or 10 to 20-fold greater than the influence of needle sharing. In other words, what this is saying is that it's not the needles, it's the virus. If we address the virus, the needles by themselves will not transmit HIV. Of course, they will do other things, but HIV can be addressed. I love telling the story. I presented this data at an international conference, and a very reputable North American scientist from Baltimore at the time stood up and congratulated me on the results. He went on to say, Julio, as you know, I've been working on the ALIVE cohort, which is similar to the virus cohort, for so many years, looking at the same issues. And I must confess, your data is very interesting, but I don't believe it. That's typical North American complimenting for you. And it's a lovely environment I live in, the academic environment, right? And I said, well, look, David, what's your problem? I mean, the data is very compelling, it's very strong. Do you have any problems with the analysis? And he said, I don't know, I need to look into it. But let me tell you, if there is something that is 10 to 20-fold greater than needle sharing, a driver for HIV infection, I should have found it. because I've been looking for it all this time. I said, well, you know what? I'll give you our paper. You have a look at it and see what happens. And lo and behold, he never called me back. But in 2011, I was walking around in the corridors in Croy, and I came across this paper, Heart Reduces HIV Incidence in IVU. And I said, well, that looks pretty good. I wonder who the author is. And it was Gregory Kirk et al. The last all of those was David Blahoff from the live cohort. They had actually reproduced our analysis, and it shows exactly the same thing. And I think it's important that I show this because independently, this verifies the fact that treatment as prevention works everywhere that it has been looked at. There is nowhere yet that treatment as prevention has been shown not to work. Importantly, they looked at providing a numeric estimate of the impact of treatment as prevention in this very, very risky environment. And what they found was that for every log of viral load that you decrease in the community, which is equivalent to say for every 90% that you bring the viral load down, you decrease transmission by 74%. Now think about that for a moment, because this is huge. The community viral load in, say, the downtown east side, before you put the antiretroviral therapy in the community, is going to be, well, it used to be, somewhere between 100,000 and 1 million copies per milliliter. That's in the order of 6 to 9 to 10 logs to 12 logs. So we're talking about a dynamic range that this is this huge. If you have the opportunity to bring down the viral load by 6 or 9 or 10 or 12 logs, means that for every log or every 90% that you reduce it, you bring down the likelihood of transmission by subsequent 74%. This is 74% and then 74% reduction and another 74 and another 74. What that means is that if you reduce the viral load from the very high level in an untreated community to an undetectable level, virtually there is no transmission. And this is exactly what we're saying. That's what we've seen in the community, and this, in fact, has now been verified in a randomized prospective controlled trial that the Americans conducted to look at this issue in HIV serodiscordant couples, which is known as the HPTN-052 study that came out eventually in 2011. The study was terminated early, much earlier than it was anticipated, because the difference between the arms was absolutely dramatic. I'll show you the data here on transmission in serodiscordant couples that were randomly assigned to receive either immediate treatment or deferred treatment, as it was the norm in Africa and India predominantly, where this study was conducted. And what you see here is that immediate therapy was associated with a 96.3% reduction in the HIV incidence measured prospectively. And furthermore, in a subsequent paper, they showed that the immediate arm had only one HIV transmission, and that single HIV transmission occurred around the time that the patient was randomly assigned to treatment, before the treatment was actually active. Therefore, concluding that if you are on treatment, effectively treated, virtually, the likelihood of transmission goes down to as close to zero as you can possibly imagine. Of course, people were advised to use condoms here, and all of the continued, prevention advice that you want, but you know how that works in real life. The reason why I'm not making an emphasis on that is because the same advice was given to both groups, and the 96% is over and above anything else that they were doing to protect themselves. So this is absolutely huge. The other point that I'm not going to elaborate on, but I want to emphasize, is that there was a demonstrable, statistically significant benefit to the individual by being treated immediately. There was a 41% reduction in morbidity and mortality, and there was an 87% reduction in tuberculosis in this cohort by being treated immediately. So let's be always very clear. We're talking about preventing morbidity and mortality, and secondarily, affecting transmission. Now, people are interested often to know why, Julio, is it that every piece of data that we see suggests that treatment as prevention is actually more effective to prevent transmission than it is to prevent disease progression. And the answer is very simple. the relationship between CD4 decline over time and disease progression is exponential. So the likelihood that people are going to progress increases dramatically as the CD4 count declines. Therefore, the advancing treatment, the marginal return on the investment, if you want, at the individual level decreases over time. It's always there, but it decreases over time. So if you want to get the biggest difference between treatment and no treatment, go ahead and treat people at 200 CD4s. Some treated immediately will die. A lot more will die if they don't treat them. The problem here is we're trying to prevent morbidity, mortality, and we want to preserve immunity and quality of life. So we need to move treatment up the ladder for their benefit. Now, the relationship between transmission, between CD4s and transmission is not relevant. The relationship is between viral load, and viral load is a much more constant variable over time. And so there is no great variability, except for the acute infection period, which is very narrow at the end of the day, but there is no variability in terms of the likelihood that people are going to transmit, for the most part. And so the efficacy of treatment for prevention of transmission is always very high, no matter where you apply it. The efficacy of treatment for the individual is huge at the distal end, and the return on the investment, if you want, decreases as you move to CD4 counts of 500, 700, or 900. Let me move on now to illustrate for you the impact that the treatment has had overall in the province of British Columbia. And, you know, we're lucky. We've been very fortunate that destiny somehow led us to a situation where we, upon discovery of triple therapy, our province was among the first jurisdictions in the world that launched the program. Why? Because we knew before anybody else, and therefore the ministry already at that time was positively engaged in allowing us to do this. So the summer of 1996 came, at the Vancouver conference was really the marketing campaign for the new treatment, and the next day people were lining up to take triple drug therapy. It worked fabulous. And you see there, phase 1, very rapid uptake of triple therapy until we practically saturated the indication of the day. We reached a plateau on the phase 2 at a time in which clinicians, you may recall, including myself, in fact, some of the papers were our own, had concerns that with only 1 or 2 rounds of therapy available, complex regimens, and resistance growing, we needed to be a little bit cautious and maximize the opportunity for treatment, or optimize the treatment based on the available opportunities. So we had a phase 2 whereby people were coming and going, if you want, taking treatment interruptions and the like, and so the number of people on treatment in the province remained steady for a period of time. In 2003 or thereabouts, as new regimens became available, and data also from randomized controlled trials showed that treatment interruptions were actually lethal, not just bad for you, but it could kill you, we totally and drastically changed our approach, and we recommended more aggressive treatment. The government, again, continued to be supportive, and as a result of that, you see a new phase of continued enrollment, not as steep as phase 1, but nonetheless, gave us the opportunity to look at the impact of treatment on morbidity and mortality through phases of expansion and a steady state, and then prospective re-expansion. As you can see in this slide, the CD4 counts over time have increased at baseline, indicating that we are starting treatment earlier, which is good. No, however, not as early as I would like to see it. Notice that the median CD4 count is still below 400 as of 2011. I don't have the 2012 data. Also notice that when I show you the frequency distribution of patients entering the treatment program, we still have on the darker blue shades at the bottom, although less, but we still have a number of people that are starting very, very late. The dark purple there is less than 50 cells. The dark blue is less than 200 cells, and the lighter but still dark shade of blue is below 350. Starting people below 350 is medically inappropriate. There is absolutely no excuse why people should start 350 or below. That column should disappear altogether. You may have issues how soon you start. Above that, our position is that immediately is the way to go for the reasons that I indicated. But below 350, the mortality data is so strong that we should be making a strong plea for people to move quickly on to starting treatment before a CD4 350 for sure. The Americans early on were very negative about this approach because, particularly in California, they have seen, given the fact that they have a weak, well, this still have a weak medical system, they have lots of leakage in their casket of care, and therefore resistance for them is a huge problem. It's a problem for everybody, but for them it's huge. And so they argue that by treating more people and treating earlier, we were going to promote resistance. I show you this slide to indicate that over time, despite the fact that we have dramatically increased the number of people on treatment, in our system, we actually not only have preserved, but actually slightly improved virological outcomes, measured as viral load suppression less than 50 or less than 500. We need to continue to strive to do that. As we move into groups of people that need more support, we need to ensure that we don't compromise these outcomes, because if we do, actually we're not doing any good. We would be creating a problem. And when it comes to achieving the goals of the strategy that Chiro outlined for you, I'm happy to tell you, don't tell Chiro this, but we are 90% there. So this is an easy one. All we need to do is carry on doing what we're doing, but a little bit more. Because look at morbidity in the province of British Columbia. We can, with very little effort, we can take this to the next level. Morbidity measured as age progression in BC has decreased by an order of magnitude. This is absolutely fabulous. All we're asking is we need to sustain the gains and just go one extra mile so that we can bring this baby under total control. And Chiro wants that we control mortality, and guess what? We're almost there. Chiro, I want my check.
It's coming April 1st.
There you go.
Yeah.
So I'll report on April 2nd. How is that for a political good news? So we're there. The reality, this is a no-brainer. What we are asking is to do more of the same. What we don't want to see is a Saskatchewan situation in British Columbia. I'll show you Saskatchewan in a moment. And from a populational perspective, this is a beautiful way, to my eyes, it looks like a tick occurred to me. It's a beautiful way of displaying what's happening with the community viral load. So what you see here is over time the frequency distribution of viral loads. On the green, on the lower shade of green, the darker green, you have people who are suppressed. You see, we have gone in 1996 from a situation that virtually everybody was viremic in the province to a situation where today, and sorry, let me qualify this. This is about everybody that has had ever a viral load in the province, whether or not ever on treatment. So this is as close to a community viral load as you're going to get. And the point is, you have approximately 55% of the people that have a viral load ever in BC who have an undetectable viral load. What that means is we have, from a transmission perspective, we have subtracted 55% of HIV-infected individuals from the HIV donor pool. That's it. So that's the reason why the strategy works. And more importantly yet, we have done so, and in addition, we have selectively decreased the people with high viral load, because naturally, treatment targets preferentially people with higher viral loads using the traditional approach. So you see the orange has gone from approximately 45 to approximately 10, 15% of the people that we know with the viral loads. So this is the reason why transmission is decreasing in British Columbia, because the amount of virus that is circulating in the province is going down. And preferentially, the high viremic people are being under control. So what happens? Well, on the blue, you see the number of people on treatment. I showed you that slide already. And on the red, you have the number of people that are being diagnosed every year. This is not an incidence slide. We don't have incidence data. It's very hard to get incidence data, but this is the best surrogate that you're going to get. We're testing more, we're testing much more, and we're finding less and less and less. And as you can see, the shapes of these curves is actually reciprocal. The more you treat, the less you've diagnosed. The faster the blue goes up, the faster the red comes down. So what's the bottom line? Let's get that blue line going up and up and up as fast as we possibly can, and you're going to see that your red line is going to go down and down and down. And by the way, the green line is injection drug users. You see that the injection drug users in British Columbia are behaving exactly the same. And I'm delighted to tell you that Mark Gilbert and his group, they released the data 2 weeks ago for the year 2012, and in the last year, the number of new diagnoses in British Columbia is down again. And this is despite the fact that over the last year, we have been going out and testing even more people and finding people that we didn't even expect that were going to be positive, where we didn't know they were HIV positives. So what that means is there is a bias acting against the hypothesis that the number of cases is going to continue to go down, and yet it continues to go down. I am confident that this is a marker of the fact that we are rapidly eroding the base of HIV-positive undiagnosed people in the province of British Columbia. And this is happening, all of this is happening at a time in which all of the other blood-borne and sexually transmitted diseases continue to transmit just as well or as bad or whatever you want to call it as they used to for the most part. So this is a selective impact on HIV, can only be explained by treatment as prevention. Whether it's syphilis, gonorrhea, chlamydia, or hepatitis C, they are either stable or going up in the province of British Columbia. So treatment as prevention is working. Unfortunately, we need to do more to control these babies. And as Chiro indicated and Arlene pointed out, we are at the tipping point of recognizing that we have an opportunity to use the seek and treat approach to really change the way we practice medicine, to really affect high-burden conditions that can be effectively treated and can be effectively prevented. Using this approach, all of these can go south in a matter of a couple of years. And as I said, this effect, or Arlene mentioned, this effect is unique to British Columbia. Nowhere else in the country they have seen something like this. And this is not by chance, and this is not because I'm here. This is because the government of British Columbia has been uniquely supportive of this approach, first. Second, because we have a program in British Columbia that is exclusively focused on seeking and treating people with HIV. We had that even before we knew what we were doing. Why? I don't know, because we're crazy. It doesn't matter. Probably because we have high burden. It doesn't matter. We did the right thing because we wanted to do what we thought it was right at the time. But back in the early 90s, when we created the center, we made the best possible investment, because by focusing our attention, look at what happens. If people with HIV don't come to us, we have nothing to do. And, we're very restless. So we go and find them. And we create cohorts, and we create initiatives, and we go out. And by doing all of that, unbeknownst to us, because we were trying to do the best for people infected with HIV, we found a way to stop the epidemic. No other province has a focused program. So what happens? They have people like you and me, but they're sitting at home or in the office, and they're doing HIV if the people come. If they don't come, they do diabetes. Or if they don't come, they do pneumonias. If they don't come, they do diabetic foods. And so what happens is the system is happy to sit back and wait for people to come. And because of that, they're hurting themselves. And that's the problem in the rest of the country. Finally, and this is very important, British Columbia is the only jurisdiction in this country where HIV care is truly, truly free. In every other province, call it whatever you want, co-payments, deductibles, or some other trick, there is an economic financial disincentive for people to access treatment. And more, as people in socio-economical disadvantaged situations need access to these services, any barrier that you put in front of them compromises the efficacy. And British Columbia is the only jurisdiction that has understood that investing more on outreach and services and facilitating access to the treatment actually pays by itself. In fact, it saves you money. And when I go to Ontario and I talk to the Minister of Health there, they said everything is fine here. Well, it's not. You see it there. So the strategy is very simple. We need to do more testing. I'll be quick. you're going to talk about testing a lot, so I'm not going to go there. And you're going to hear about this more, so I'm not need to bother with that. We need to apply the guidelines. We need to stop writing new guidelines and just apply what we have. In 2010, we had guidelines that said we need to change the proposition. It's not who qualifies for treatment. It's you need to explain to me, why are you not offering treatment to this person? And the only clinical situations were not offering treatment. I didn't say order. I didn't say mandate. I didn't say oblige. I said every person with HIV should be offered antiretroviral therapy and should have the right to choose to treat or not to treat the person. But our medical recommendation is you'll be better off on treatment unless your CD4 count is very high, way over 500, and at the same time, your viral load is either undetectable or very, very low, below 500, in the absence of antiretroviral therapy. The latter is defined as either elite controllers or long-term non-progressors, which, by the way, represents somewhere between 0.1 to 1% of the people infected with HIV in British Columbia. So in that situation, you're better off saying everybody should be offered treatment, and if you're not going to offer it, you think about why not? Why is it stopping me from doing that? And if there are socioeconomical disadvantages and situations, it's our responsibility. The STOP program has the responsibility to address them so that we can make that happen. I wanted to give you the impression that what it was the norm back in 2010 for the International AIDS Society USA, and we thought it was the way to go, has now become the norm for the DHHS, the Department of Human Health and Services in the United States. And now the WHO has recommended the same thing. And not only that, in confidence, and I don't care if it's on the tape, I'll tell you that the WHO is getting ready to announce this summer, with a number of caveats, that everybody in the world, including Africa, should embrace the 500 at the minimum threshold where antiretroviral therapy should be offered to everybody. And over and above the CD4 of 500, they will recommend treatment as prevention for selected groups, which includes serodiscordant couples, pregnant women, key populations including sexual workers, IDUs, and MSM. Now, if that's not universal test and treat, tell me what? Who is left out? Nobody. So if WHO is recommending this for Africa, what are we waiting for? Few minutes on the casket of care. Testing and treating for us comes natural. As prescribers, as treaters, we understand that. The issue is that for this to work, it is critically important to look after to everything that is in between. And Chiro introduced the concept of casket of care. What this is a mapping exercise that allows us to find out where people are in the continuum of care from HIV at risk to HIV undetectable. And that's described in this slide here. This was first proposed by Gardner, and it looks at the situation in the United States. You have people who are HIV infected, HIV diagnosed, linked to HIV care, retaining HIV care, in need of antiretroviral therapy, on antiretroviral therapy, and then adherent and undetectable. In the United States at that time, they had less than 20% of the people being undetectable. That's the reason why they don't have an epidemiological impact. It's because their program doesn't work. They reviewed this data the following year, and they suggested that it may be more like 28. Well, it's still pretty bad. In British Columbia, we have looked at this issue on a sequential basis, going from 96 to the present, to 2010, and you find that, fortunately, our casket of care is getting better all the time. It's not fast enough, it's not good enough. We're going to use these metrics to try to help everybody understand what's going on in your region, in your area, in your clinic, in your risk groups, because this is not a homogeneous cascade of care. It behaves different in different people. And to give you an example, this is the cascade of care stratified in BC by age, and you see that there are differences. And I'm not going to go into the details. And now you complicate the analysis more, and you have stratified by IDU by age, and then you learn some more. You find where the holes are. Is it more proximal, more distal? Is more adherence? Is more retention? And this will inform our programs where the emphasis should be. You can do that by MSM. You can do that by gender. You can mix them all up. You can do it by zip code, by health authority, and all of this data is still preliminary. We're linking data from all of the health authorities so that we can put it all together and they start slicing the pie so that you know precisely what's going on in your region, and then you can try to address each one of the steps of the cascade of care. Couple of words about money. Everybody worries about money. You need to know that this strategy is cost-saving. The WHO has shown on the left that if we do this in Africa, for example, the more you treat, going from the blue to the pink or whatever that is, yellow and blue, ultimately treating everybody, you save millions of lives. But that's one point. When it comes to the money, you notice that on your right-hand side, by treating more, it costs more up front, but the savings accrue very, very quickly. And the data in British Columbia shows it. This is a very effective and cost-effective strategy in the very short term. So there is every reason to do it. You need to know that so that you can tell your peers, we're prioritizing this because it is life-saving and cost-saving. And then people are going to ask you, you know, guys, this Julio thing, he's enamored with antiretroviral therapy. He's a pharma guy, and we're sick and tired of it. And let me just address that right away. The problem is that when you look at biomedical interventions to prevent HIV transmission, treatment as prevention is by far the most effective one. And this is not my paper. It's from The Lancet, from the guys that wrote the microbicide paper. So this is not biased. On the top, you have treatment as prevention. On the bottom, you have vaccine. It doesn't work. And it's going to be a long time before we have an effective vaccine. And then you have, I can't even read, but it doesn't matter, microbicides, and you have PrEP. Now the PrEP slide here is incomplete because it misses at least 3 different studies that have shown that PrEP had zero efficacy. They were interrupted because there was no efficacy. Why? Because PrEP requires high level of motivation. And people that are not HIV infected, they're not equally motivated than those that are infected. Sorry, PrEP is pre-exposure prophylaxis, meaning taking Truvada, 1 pill once a day, every day of your life to prevent acquisition of HIV is if you're at high risk. So the point is, you're investing a whole lot of effort. You're going after people that are not quite equally motivated, but more importantly, who is your target? It's a shifting target. And how do you identify it? There is no test. You have to go ask, find out. On the other hand, treatment as prevention, you can identify them, they're motivated, they need it. We already decided that we're going to treat them, so by treating them today, we're just accelerating the process, but they are getting what they need to get. And let me remind you, treatment as prevention derives a prevention benefit for free. There is no additional infrastructure. There is no additional expansion of medicines. There is no competition for resources. You treat the people that need to be treated, and you solve the prevention puzzle independently. So it is by far the more effective, but in addition to that, is actually free. So it's not that we like it, it's the smart investment. And Michel Sidibe, the executive director of UNAIDS, recognized that in 2010, and he embraced it enthusiastically when he visited Vancouver at that time. President Obama started talking about the beginning of the AIDS of the beginning of the end of the AIDS epidemic, and I think that we truly can say we're on the right track. And President Clinton has been wonderful, and he has continued to support our efforts ever since. And that lands me on the announcement that Minister Margaret McDermott and Minister Sultan made on the eve of the International AIDS Day last year. And as Arlene said, I have a great deal of gratitude to them for that announcement. Remember, they have confirmed the expansion of the program before the pilots are finished based on the compelling results that we've been able to generate to date. And I also want to remind you that the funding, although it has not been totally disclosed, and I haven't even seen the details of it, is incentive funding. So we need to go back to our masters and our bosses and remind them, this is not a line item in your budget, and we use that and it's over. This is for us to deliver on the priorities that the ministry document put forward, and is not proportional to the money, because we're going to need more money to do the work, and we need to ensure that we're not going to be cheap. being cheap about it will be a disaster. Thank you.
So we're running a little behind, but I'd like to take the opportunity of having Julio to respond to any questions that people might have. So we've got about maybe 10 minutes, and I see Trevor with a question, and so why don't you kick it off? If you could come to the microphone, Trevor, so everyone can hear it, and others, just flag me if you've got questions.
This is a little short for me. I'll just bend over. Thanks, Julio. That was a super talk. One of the things that I've discovered in my conversation, in particularly with physicians who have lived through the last 10 years, the conversation around resistance above the CD4 count of 500 is very real to them. How would you describe on a population base sort of resistance now in 2013 versus resistance in 2005? How can I explain that to the physicians that I'm working with?
No, that's an excellent question. Is there going to be a Richard Harrigan presentation?
I don't.
I'm going to be sure that you see the data on resistance, because me describing it is irrelevant. Well, I hope not, but you know, it's so graphic, and I'm sorry I didn't introduce it here. I have it in the slide collection. It is remarkable, but resistance in the province of British Columbia has gone down markedly, and we have expanded. I showed you suppression. Suppression already tells you that resistance is down, because suppressed people are not showing resistance. They could harbor resistance, but they're not showing it. What that means is that our system of treatment has become more effective. So we treat more, we go higher CD4s, we go to people in difficult circumstances, and yet we suppress more with lesser resistance. Not only there is less resistance overall today than there was in '96 and in 2000, but the quality of the resistance actually has changed. We virtually, don't get me wrong, we still have problems, but virtually no longer have multiple drug resistance as we used to have. Some of you recall, because Dwight is sitting there and a number of others who have been through my office, that I spend at least 3 days, 12 hours a day, addressing problematic patients in my office. Well, guess what? I don't do that anymore. It doesn't exist. It's not there. And it's not just because we are such a genius. It's not because the patients are dramatically more compliant. It is also because we have remarkably better drugs. So the truth is that we have safer, simpler, more compact regimens that are better tolerated. And even if those fail, we have backups that are remarkably effective. So altogether, the package deal is working to our advantage. So the time to do this and do it right is now.
Evan, was that a question coming from you?
Yes. Good morning. This is Evan Jones with the Pacific AIDS Network, and I actually have a question for Chiro. Chiro, do you have a sense yet of how the funding is going to break down across the regions for the provincial rollout?
We do have a pretty good idea. So in the coming weeks, I think the steering committee is going to be meeting again for which brings together all the CEOs for the health authorities in early mid-February. And so I think shortly after that time, there'll be some more specific communication around the funding for everyone.
Thanks.
Thanks.
Any other questions? Irene, you've got a question for Julio?
Julio,
Okay.
I'm wondering if you would address if there's any difference in whether you're First Nations or you're Black in terms of how antiretroviral impacts.
You know, that makes me smile, because when we started doing antiretroviral therapy, the Americans would do stratify analysis by ethnicity. And being a Latino as I am, I would walk into a room and they had an oral abstract presented at CROI, stratified by white or Latino. And I would say, so what are we, different or something? The antiretroviral therapy doesn't discriminate. Treats everybody the same. And our data shows that. And it shows that it's true for Black, for Latino, for First Nations. We have the data. Now, if there are social, cultural determinants of health that need to be addressed, then you need to address those, because it's not a biological difference, but rather a social, cultural, economic, and issue. And so, yes, if you go to the United States, retention levels are worse on Blacks, and guess what? It has nothing to do with race. It has to do with social, cultural determinants, and the United States have a huge problem there. We have problems with minorities here, whether it's with the newcomers, minority immigrants, or seriously in the First Nations. But we have a lot of success stories among the First Nations, and we have shown that when we engage appropriately, they are so equally responsible as anybody else. So the potential for this to do good across the board is, I would say, 100%.
Okay, I'm seeing nobody jumping up, so I'll say thanks very much, Julio, and I guess it's back to you, Cheryl.